Hello, everyone, and welcome to our module on cholinergic toxidromes. Let's start by reviewing a little bit of vocabulary. So the word cholinergic means related to the neurotransmitter acetylcholine and its receptors. And the word toxidrome means signs and symptoms of a toxin exposure. So in this video on cholinergic toxidromes, we're going to talk about toxidromes where there's cholinergic activity throughout the body, in other words, overactivity of acetylcholine receptors. And then we're also going to talk about toxidromes associated with anticholinergic activity where there's widespread blockade of acetylcholine receptors throughout the body. Let's start by talking about cholinergic toxidromes. So this is a toxidrome where there's widespread activation of acetylcholine receptors throughout the body. And the classic cause of a cholinergic toxidrome is exposure to organophosphates. Organophosphates are substances found in pesticides, and when humans are exposed, what happens is the organophosphates inhibit the enzyme acetylcholinesterase. So what does this enzyme do? Well, to understand this, let's look at this drawing on the screen here. So this is a depiction of the enzyme acetylcholinesterase, and it takes the neurotransmitter acetylcholine and breaks it down into choline and acetate. And so when you inhibit this enzyme because of exposure to organophosphates, you get increased levels of acetylcholine at synapses throughout the body and general overactivation of cholinergic receptors. The way organophosphates cause this inhibition of acetylcholinesterase is by phosphorylating the active site of the enzyme. This renders the enzyme inactive, and then, as I said, acetylcholine accumulates, and you get a cholinergic toxidrome or a cholinergic crisis. There's a mnemonic that's been used for a long time to remember the clinical features of a cholinergic toxidrome, and that mnemonic is dumbbells. Each of the letter in dumbbells stands for one of the clinical features of this toxidrome, and I've listed them all here. Basically, all of these clinical features are the effects of the parasympathetic nervous system. It uses acetylcholine as a neurotransmitter. So when a person is exposed to organophosphates, basically you turn on the parasympathetic nervous system, and that's what leads to all these effects right here. And we'll go through them in the next couple of slides. So one of the first clinical features of a cholinergic toxidrome is increased GI motility. This leads to many of the signs and symptoms. So this can cause patients to feel nausea, it can make them vomit, they can have abdominal cramps, and they can also have diarrhea. A classic feature of a cholinergic toxidrome is diarrhea. Also in a cholinergic toxidrome, you have activation of secretory glands. So patients will sweat profusely because that's mediated by acetylcholine. They will salivate, and they will also lacrimate, meaning their eyes will become teary. All of these things are mediated by acetylcholine binding to muscarinic receptors. And then in the bladder, the detrusor muscle contains smooth muscle that's activated by acetylcholine working on muscarinic receptors. So in a cholinergic toxidrome, patients can lose urine. They can complain of involuntary urination, and this, along with diarrhea, are classic features of a cholinergic toxidrome. In the heart, acetylcholine activity decreases contractility and also slows the heart rate. So bradycardia is a classic feature of a cholinergic toxidrome. In the lungs, acetylcholine on muscarinic receptors causes bronchoconstriction, so patients can present with wheezing and dyspnea. If they have a history of asthma or COPD, they can experience a flare of those conditions. And then there are a couple of effects of a cholinergic toxidrome on the eyes. First of all, the pupils will shrink and become pinpoint. This is called miosis. I talk about it in videos in the ophthalmology section. Also, the ciliary muscle of the eye helps us to accommodate, to have near vision for objects close to the eye. And this is affected by acetylcholine on muscarinic receptors. So patients can complain of blurry vision. And then, as I already mentioned, patients will have watery eyes. That's lacrimation. So these three features here in the eyes, miosis, blurry vision, and lacrimation, all classic features of a cholinergic toxidrome. Now, as I mentioned, acetylcholine is the major neurotransmitter of the parasympathetic nervous system, but it's also an important neurotransmitter in the somatic nervous system, which involves voluntary control of our muscles. So in a cholinergic toxidrome, when levels of acetylcholine are boosted throughout the body, this will also affect muscles, and patients can develop muscle twitching from acetylcholine binding to nicotinic receptors on muscle fibers. There are also acetylcholine receptors in the central nervous system in the brain, and so overactivation of these receptors can lead to symptoms like confusion, lethargy, and seizures. And so these things are also potential features of a cholinergic toxidrome. And you should know that the way people die from organophosphate poisoning and cholinergic toxidromes is from respiratory failure. There are a couple of mechanisms that contribute to this. First of all, the secretions in the lungs can get very high in a cholinergic toxidrome. This is called bronchorrhea, so patients basically can drown in their own respiratory secretions. And then, as we've mentioned, bronchospasm is a feature of cholinergic toxidromes, so this can affect respiratory function. And then finally, patients also develop muscle weakness from that overactivation of receptors in the somatic nervous system. So all three of these things can conspire and lead to respiratory failure, the major cause of death in a cholinergic toxidrome. So here's just one example of how organophosphate poisoning in a cholinergic toxidrome might be described in a board question. So let's imagine they tell you about a 44-year-old farmer. A farmer is a classic profession to be exposed to organophosphates and pesticides, and he presents with difficulty breathing. There's audible wheezing, so remember that wheezing is from bronchoconstriction. He also reports diarrhea and unintentional loss of urine. So right away, you're getting a picture of organophosphate poisoning here. Then they tell you that he's confused. This is from central nervous system effects. On exam, he has pinpoint pupils. He's sweating, he's drooling, and his eyes are watery, and he's bradycardic with a pulse of 30. So learn to recognize this presentation right here, classic presentation of organophosphate poisoning and a cholinergic toxidrome. The typical treatment for a cholinergic toxidrome usually involves two drugs. The first one is atropine, which is a muscarinic receptor antagonist. It's the first-line therapy for a cholinergic toxidrome. The reason it's first line is because it has a rapid onset of action and also because it reverses many of the life-threatening components of a cholinergic toxidrome. So it reverses bradycardia, the bronchuria, also any hypotension from bradycardia. All these things can be life-threatening, and they are reversed by atropine. Importantly, though, it has no effect at nicotinic receptors, which are found on muscles. So this is very high yield to know for your board exams. Atropine is not going to reverse muscle weakness or muscle fasciculations. That's because it's a muscarinic antagonist, not a nicotinic receptor antagonist. After you give atropine, you give pralidoxime. This is a drug that regenerates acetylcholinesterase, the enzyme that's inhibited by organophosphates. Remember that we talked about how cholinesterase enzymes are inactivated by phosphorylation. Well, what pralidoxime does is it reactivates them, and it basically undoes the effects of the phosphorylation of the enzyme. This is always given after atropine. The reason is that when you give atropine, for complicated reasons, there can be a transient surge in acetylcholine effects. And so if you were to give pralidoxime without atropine, you could see worsening of bronchuria and bronchospasm, and that could be life-threatening. So atropine is given first, and that's because it reverses these life-threatening effects, and then you can give pralidoxime to regenerate acetylcholinesterase. Okay, so that's a cholinergic toxidrome. Now we're going to go in the opposite direction and talk about an anticholinergic toxidrome. This occurs when some drug or poison has been administered that blocks cholinergic receptors throughout the body. This can happen if patients take too much of certain drugs. For example, antihistamines like diphenhydramine, although they are antihistamine drug, they also have effects where they block acetylcholine receptors. Tricyclic antidepressants like amitriptyline have anticholinergic effects, and so an overdose of these drugs can lead to an anticholinergic toxidrome. And then atropine, which we just talked about in the last slide, if you give a patient too much atropine, that patient will develop an anticholinergic toxidrome. And then there are certain plants that have atropine-like compounds in them. The classic plant that does this is Jimson weed. It goes by the official name Datura stramonium, and if patients are exposed to Jimson weed because of its atropine-like effects, that can potentially lead to an anticholinergic toxidrome. So now let's talk about the clinical features of an anticholinergic toxidrome. They are essentially the opposite of what we talked about for a cholinergic toxidrome. So in an anticholinergic toxidrome, the skin becomes very dry because you're blocking acetylcholine effects at sweat glands, which are innervated by the sympathetic nervous system. When patients can't sweat, they can't dissipate heat, so they will develop hyperthermia from loss of sweating, and their body temperature can be high. And then the skin of the face and other areas in the body can become flushed, meaning it can look red, like in this picture on the slide here. This is because when there's hyperthermia and the patient cannot sweat, they will vasodilate blood vessels in the skin to try and dissipate heat. And so dry skin, hyperthermia, and flushing, these are all classic features of an anticholinergic toxidrome. In an anticholinergic toxidrome, patients develop dry mouth and dry eyes because they cannot lacrimate or salivate. This is the opposite of what we talked about before for a cholinergic toxidrome. The pupils in an anticholinergic toxidrome are dilated. This is mydriasis. That's what's shown in this image on the slide here. This is the opposite of the pinpoint pupils of a cholinergic toxidrome. When the pupils dilate, this can trigger acute angle closure glaucoma, which I talk about in the ophthalmology section. But it makes it more difficult for the anterior chamber to drain fluid when the pupil dilates. And so in an anticholinergic toxidrome, someone can develop acute glaucoma potentially. The lens is unable to accommodate in an anticholinergic toxidrome, so this can lead to blurry vision. And then blockade of central nervous system, meaning brain acetylcholine receptors, can lead to delirium. So the time-honored mnemonic to remember the features of an anticholinergic toxidrome are shown on this slide. The mnemonic goes: red as a beet, dry as a bone, blind as a bat, mad as a hatter, and hot as a hare. I summarized all these things for you right here. They are all the clinical features of an anticholinergic toxidrome that we talked about on the last few slides. The treatment for an anticholinergic toxidrome is with the drug physostigmine. This drug is an acetylcholinesterase inhibitor. It's an indirect activator of acetylcholine receptors, and I talk about it in more detail in the video on cholinergic drugs. But it has a chemical structure of a tertiary amine. This gives it the ability to cross the blood-brain barrier so it can reverse those central nervous system effects in addition to reversing the peripheral effects. And so by inhibiting the enzyme acetylcholinesterase, similar to what organophosphates do, it will boost acetylcholine levels. And in the case of a person suffering from anticholinergic toxicity, this will resolve many of the symptoms. So I don't know about you guys, but when I was a student, I always got confused between cholinergic and anticholinergic toxidromes. So in this slide, I've summarized the two different types of acetylcholine synapse poisoning. So a cholinergic toxidrome is classically caused by organophosphates, and that leads to nicotinic and muscarinic receptor activation. So these patients are wet, they're drooling, they have teary eyes, they're sweaty, they're slow, they have bradycardia, and they're also small, meaning they have pinpoint pupils, like what I've shown right here on the slide. And then an anticholinergic toxidrome is classically caused by the plant Jimson weed. This leads to muscarinic receptor blockade. So these patients are dry, they have dry mouth and no sweat, and they are dilated, meaning they have mydriasis. And that's what's shown here, dilated pupil. That goes with anticholinergic toxicity. And that concludes our module on cholinergic toxidromes.